care in the time of COVID. Thank you very much for logging in at this relatively early hour. I hope you're all well and comfortable for the next 60 minutes or so. It's great to see so many of you there. My name is Laura. I'll be the host, so I will disappear very shortly to just sort out slides and things like that. We will keep an eye on the chat. So please, if you would like to contribute or ask a question, do write in the chat. But I would like to immediately hand over to Charlotte Augst from National Voices. Charlotte, over to you.
Hello, everyone. I think I might have mucked up my view. Are there slides showing right now? Because I can't see any of those. I just got the speaker view. Is that the view I want?
So it's not yet.
Okay.
If you just want to say a couple of words, and then I'll put the slides up straight away.
Okay. So, yeah, my name is Charlotte, and I'm the Chief Executive at National Voices. It's very lovely to see so many of you here this morning. We had to actually change platform because so many of you joined us, which is great. We at National Voices are thinking hard about how we can make sure that the decisions we take now going forward are fully sighted of the experiences people actually have as they live with ongoing health and care needs during this period. And so I was really pleased when I met Jessie from Traverse, who said they've done a small piece of research at breakneck speed, which seems to be how we do anything these days, to find out how people are making decisions about using or not using services and how they are experiencing service closures or service delays. So I thought it'd be a great opportunity to air that research and put it in front of people who need to know what it's telling us and discuss with you what we think it makes us realize that we didn't know before. And then also talk briefly about work we're doing under the Our COVID Voices heading, which is an attempt to, in a way, crowdsource a first draft of history of what's actually going on, and to really put people with ongoing health and care needs at the center of decision making as we need to design health and care services for the next period. So we've got Lucy from Traverse talking about her research. We've got an interesting panel. Unfortunately, Simon had to drop out at the last minute. I think that's why I could never work in communications, because you're never in charge of your day. So we don't have him, but we have David McNally, who leads on experience of care at NHSE and I. And we've got Martin Marshall, I hope. Has he joined us by now? Martin, have you joined us? Yeah?
Martin's on the call, yeah.
Oh, excellent.
Yes, thank you, Charlotte.
Who's going to talk from a primary care perspective, obviously. So there's going to be a bit of a panel discussion, and then we move on to asking you what you think and what you've heard and what you think we should be doing next. So few technical comments. I think I need to say that we're going to mute you, but you can signal by raising your hand or
So you can signal basically your intention to speak. As I mentioned a moment ago, raise your hand or write in the chat. We are recording this. We will share it later on. We will let you know once the YouTube link is up on National Voices YouTube channel. So if for any reason you can't stay until the end, or if you think you would like to share this with a colleague who wasn't able to attend, you will be able to share with them a link at some point next week. So without further ado, I'm going to hand over to Lucy Farrow from Traverse. Lucy, over to you.
Unmute. Hi, morning everybody. Okay, so thanks for joining us. I'm just going to give a kind of whistle-stop tour of the piece of lived experience work that we did shortly. I, with my colleague Jessie, from Traverse, we're a social research organisation. We're an employee-owned business, and we we work across the public sector and the private sector, in fact, on inclusive and evidence-based decision making. That's our kind of mission. So this really fits well into that kind of overall goal. In terms of what we did, if we just flick on to the next slide, we know that people's experience, that healthcare, that COVID has changed the way in which healthcare is being delivered. We know that that's had an effect on the numbers of people accessing care, and there is a wide range of evidence, data and statistics about that. We know that A&E attendances have hugely dropped off. We know that GP appointments have changed. We've got evidence from various charities focusing on particular conditions, suggesting that things as serious as cancer diagnoses have been delayed. So knowing all of that, what we wanted to do is to think about what's that experience of care changing, being delayed or being avoided like for the people who are living it. For us, the lived experience approach really is about trying to hear the stories of the people affected and to tell those as directly as we can. In order to do that, we carried out a very rapid process of interviewing around a dozen people. This was just at the beginning of the second lockdown period, so people had already done, everybody had done 3 weeks in lockdown. For many of the people we spoke to who had existing conditions, they had been isolating for longer. And the people that we spoke to had a mix of care that had been cancelled, scheduled care that was delayed either to a specific date or indefinitely. And we also spoke to some people who had chosen not to seek care. And we put out a very broad call for participants. We just asked for people whose care had been disrupted, and we allowed very much people to sort of self-define that, which is very much in the kind of is in line with the lived experience approach, which is very much about letting people define in their own terms what was happening to them. Just one more thing on lived experience is just to say that we invited all of the people who took part in the research to the webinar. They have seen the research, and that's an important part of this process, is them being able to see what the outcome is. I think I was reflecting on what they would want me to say, on what were the kind of key things that I think the people I spoke to would expect to hear in this context. And I think that one of the things that they would hope to hear is that everybody we spoke to was incredibly grateful for the work that the NHS and the NHS staff were doing. So it's really important, I think, to contextualise this as not being about bashing the NHS and complaining about care. I think people would want to be very clear that what they were describing was a situation which is not ideal all round. And that was one of the things that really ran through all of the interviews that we did, was this feeling of everybody being in it together. Now, we can talk about whether that is or isn't helpful, but I think it is important to say that was really a key kind of message that came through, was this sense of people being very grateful for the care that they had received. And in most cases, people were very clear that they didn't feel unsafe. Care might not have felt good, but they typically didn't equate that with feeling unsafe. Again, we might discuss whether or not people were in fact safe, but that was the perception. So this slide just shows you that we spoke to people with a really wide range of conditions, but I will promptly move on to telling you about some of the things they said. As I said, we asked a range of people whether why they hadn't accessed care or what had happened. And interestingly, we found that for most people we spoke to, the sense of responsibility was more significant than the sense of fear or kind of personal anxiety. So everybody understood why care had been disrupted, and in many cases people had self-regulated, had decided not to access care. And that ranged in a whole range of different ways, from people who, in this case, we had somebody who contacted the maternity unit, so it's a pregnant person who felt bad about it, felt that their concern was minor. In contrast, we had people who didn't call and felt that it was it wasn't appropriate for them to ask for care. In the most serious case that we spoke to, we had somebody who had suffered a stroke and didn't ask for care for didn't contact the health service for a period of some hours. So we know that people are not accessing care. We also hear that people are telling us that's often because of this sense of responsibility rather than a sense of fear. Where people did tell us that they were anxious about accessing healthcare, that was often informed by the kinds of things that we know people already have. So it's not just about COVID, it's also about personal experience. So where people had heard anecdotes, for example, of people being infected with COVID while in hospitals, but also previous experiences. So where people had negative perceptions of a particular care setting, particular hospital, say, that meant that they were likely then to associate that with a higher risk. And even in the context of people expressing anxiety about accessing healthcare at this time, there was also concern for others. It was often about, well, if I'm going to the hospital and then coming home and I've been exposed and then I'm exposing other people, there was a really strong narrative of protecting people's families. So there's a whole mix of things happening when people are deciding to access care or not. And I'm sure this doesn't need saying, but in some cases that impact of not accessing care was huge. If we look at the next slide, we've got a quote from somebody who was undergoing fertility treatment at the time, and that was cancelled. That's a very particular example where the knock-on impact of care being disrupted is huge. But for a whole range of people we spoke to, the impacts were pervasive. Often there were people who had waited a long time for particular appointments. This tended to be more of a concern, or people who were undergoing treatment or had a condition that was over the longer term. So it was not just about that one GP appointment, that one-off care. It was more often the impact was being felt where people were engaged in a process. To talk a little bit about the experience of care when people did access it, we found that the key thing that caused anxiety or distress for people was uncertainty. I'm sure this isn't a surprise to people, but where care was disrupted and the service wasn't able to give people information, that was much more distressing than being told when, even if they couldn't be told when an appointment would be rescheduled. If people knew when they would know when it would be rescheduled, that gave them a sense of control, actually, a sense of agency, and of knowing what to expect. So a lot of the comments that the stories that we heard were about uncertainty, either appointments being cancelled the day before, but then taking place on the telephone or not taking place, or follow-up appointments being participants agreeing with healthcare providers that they shouldn't come in for appointments, but not knowing when those would be followed up. So there's a real sense in which that was often the kind of point at which people were really felt anxiety. And a lot of that related back to the kind of existing feelings of uncertainty that people have. So the quotes here describe some of the things that people were concerned about. Will I be sent to the back of the queue? So there's a concern from a participant who was attending a particular service and was concerned that if they were regarded as having missed appointments because they were shielding, then they would be discharged from the service. So there's a real kind of fear about that. For other people, this idea of being at their mercy was a concern, this idea that they didn't have control of the situation. And again, this idea of being back to square one, often for people who were dealing with long-term or chronic conditions, or as someone I spoke to particularly had waited a long time for a mental health appointment, felt that a lot of energy had gone into getting ready for that. That the care, it wasn't just a day-to-day occurrence, it was quite a significant event for them. And so feeling that that was a very significant kind of knockback for them. So that was really the kind of key thing around people accessing care, was about uncertainty. I'm now going to talk a little bit about when people did access care. What was that like? What was different? What was new? And I've given 2 quotes here, which were both from participants who were pregnant and who described separately incidents of care where they felt that things were different. And when we probed about what that was, typically it was a sense that while they were getting the care that they needed, and I said earlier that that people didn't often report that they felt unsafe, while they were getting the basics, their interactions tended to be more matter of fact. They were more pragmatic, more practical, more focused on their next steps and on immediacy. This is not necessarily surprising, but it was something that people noticed and felt that they were felt less supported. Now, in some cases, that was fine, where people were engaged with in kind of one-off interactions where there's a lower level of emotion involved, then that might be fine. But for a lot of people we spoke to who had more involved conditions and more long-term conditions, that lack of a relationship felt difficult for them, and felt as though they were often concerned about the long term. So, for example, it might be fine to miss your midwife appointment because of the lockdown, but people were then going on to think, okay, but what happens if I miss 2 or 3? That's actually quite a long time in a pregnancy. That's quite a big period of time in which I don't have access to somebody. That's time when I would have been starting to think about a birth plan. Okay, then that knocks onto what is that birth like? What are the long-term impacts of that experience being different than how I would have expected it? So that was really the thing that people were concerned about. In contrast, where people reported really good care, it was just more human. So things like acknowledging the situation. People found it really, really powerful when the people they interacted with in the health service just acknowledged that this is weird. There's nobody in this waiting room. That's weird. That there was a sense that that by acknowledging it and sharing the unusual nature of the situation, that helped to normalize it. Clarity was hugely important. People just wanted to know what was expected of them, where they were supposed to stand, whether they were supposed to come to the appointment on time or early. There was a whole set of kind of experiences where people said the best thing that they could do was just tell me exactly what I was supposed to do. And then there's this kind of aspect of all the things that we know already around consent and treating people as individuals, and all of those aspects of person-centered care, which still felt very important. And felt important not just in the settings where people work, for example, accessing hospitals or other primary care settings, but online and when they were using remote technology. So we spoke to people who'd used a whole range of different remote technology options, from phones and video calls to apps. On phones and video calls and apps, I think it's worth saying that often the experiences that were the most positive among the people we spoke to were the simplest. People really valued phone calls because they could ask questions. They were personal. Video calls were great, but it wasn't clear to me that they felt significantly different from those from phone calls. It'd be interesting to hear from people who are in primary care say what their experiences of that, but there wasn't a sense that people immediately preferred video calls or that they felt more personal. Some sort of simple things around how people experience those. University wanted to know when calls were going to happen. Some of the stories that we heard that were negative about telephone and remote appointments was just, if I don't know when it's going to happen, I'm not prepared. It doesn't feel as much space in a remote setting to just ask questions, to just just think things through. So people felt that they needed to be more prepared for those appointments, and if they didn't happen at a specified time, then that was a problem. There were also some specific examples, both good and bad, where people were less able to take part in these telephone appointments themselves. So we spoke to one person who was who had a caring role for someone in their family with a learning disability, who had a telephone appointment and really just come away very unclear about what had been agreed. Again, it wasn't. You'll see in the report, the participant actually Googled the medication change that had been made. Now that's not ideal for carers to be having to look up those sorts of things. So something had happened there where typically in a face-to-face appointment, because somebody would have taken this patient to the appointment and would have been with them, and the process would they would have done the appointment together. Somewhere along the line that had got lost in moving to a telephone appointment. So there's something there about just thinking through what happens in those situations. In contrast, one of the most positive stories we heard was a participant who had someone in her family had a stroke, and she was caring for them, and they'd had a video physiotherapy appointment, which was a really positive experience because the person on the other end of the phone, the NHS staff member, was friendly and asked questions and confirmed that things were understood, asked for consent to speak to the carer, laughed at my dad's jokes, which I thought was is something that we all know is important in care, but I thought was really it was interesting that came across even through the video. So two final things on remote care. Apps, gosh, yes, there are lots of apps that I think that's probably the dominant feature of the app situation from the stories that we heard, is that people aren't entirely sure which one they're supposed to be using. We spoke to one participant who seemed to have ended up with 3 different apps from the maternity service, none of which seemed to tell her when her appointments were. So I think there's something there about just the extent to which this technology is mature and consistent. And finally, I wanted to talk about answer phones, because this was something that which we noticed afterwards, looking across all of the interviews we'd done, was just how influential the answer phone and recorded messages were when people contacted services. So, for example, again, thinking about maternity services, there was somebody who had been given a number for a helpline. When you called the line, a recorded message told you that unless your condition was very immediately urgent and acute, then you should go on the website. And that really, this person was just very uncertain about what exactly urgent meant in the context of a pregnancy. That it felt very uncertain, and the inclination there was to err on the side of caution and not stick it out. So I think there's something really important about that. If you think about answer phone messages as a message that people experience on their own, there's no contact there. I think that's potentially a really important touch point in a kind of care journey. Okay, I talked for a little while. We put some recommendations in the report. They're really more questions. The first one was, how do we have a conversation about the right level of demand? I think we can all agree that there are cases where people are not getting care that they need. On the other hand, we could say that the level of demand currently in the NHS has been reset. So I think it's something about having that conversation. We talked about the need to focus on person-centered care, on clear communications, and on managing uncertainty. And really, those things, again, are not surprising, but this research really did underline just how important those are in this time of greater national uncertainty. We talked about the idea that health is more than a set of symptoms, and I think that's something that I've started to see in other pieces, in other kind of conversations now, is thinking about what are the long-term implications. We have done a remarkable job of keeping people safe, but that has tended to be, I always think that the great example is in mental health services. We have crisis teams, and they have continued to work very effectively. what we maybe have struggled with is the next tier up from that. So I think there's something about what's that long-term consequence. And finally, there's just a point about understanding the consequences of messaging. I think from the research we did, we found that people who had interpreted the same messages in a whole range of different ways, that those messages weren't just interpreted neutrally, they were interpreted in the context of people's existing experiences, their existing conditions, even their existing assumptions about particular hospitals. So there's a whole range of things that we need to understand when we're messaging what we expect of patients and service users. I think, again, that's something I'd be really interested to hear other people's views on. Okay, I'm going to pause there and hand back to Laura.
Thank you, Lucy. That was brilliant. Thank you for a very, very full set of slides with some very deep and interesting quotes. So without any further delay, I'd like to hand over to our great panel. So
do you want me to take over again, Laura? I think I'm back online, or do you want to?
Right. No, it's
all right.
Charlotte. Yeah.
Thank you, Laura, for holding the fort. I don't know, there's something chunky. I've got a new laptop. I don't know whether there's something wrong with my laptop. Anyway, really interesting presentation. And yeah, particularly the quotes always really bring it home, don't they? I was just wondering, Martin, do you want to be the first to react? What does that sound like for a jobbing GP, which obviously doesn't exactly do justice to the role in the system, and someone who has to think professionally about how primary care needs to respond to this insight? Do you want to just give us your first reaction?
Yes, thank you, Charlotte, and thank you, Lucy, for some really great work. It's great to see some data supporting what I think we've been feeling in general practice for a long time. So for those who don't know me, I'm chair of the Royal College of General Practitioners, and I'm a GP in Newham in East London. We've been aware in general practice that the impact of COVID on what you might call loosely non-COVID healthcare has been truly massive. We've been very aware of that and very sensitive to that from the very earliest days. And we've seen, as you described, Lucy, a significant reduction in workload for non-COVID conditions. So in general practice, according to the data that we collect, a 25% reduction in clinical workload, a 28% reduction in administrative workload. We've seen a 30% reduction in emergency department admissions, a 70% reduction in 2-week cancer referrals. So a massive reduction in work. What we have been hearing is there are a number of factors that have caused that. First of all, a patient's desire to protect the NHS, to look after the NHS. Secondly, a fear of using health services, particularly going to general practice or hospitals for fear that they might pick up the infection. Third, an active willingness to self-care, an ability to kind of hold on to problems that they might otherwise have taken to professionalised services. And then finally, a perception, or in some cases a reality, that the NHS was shut for business. And general practices have been part of that issue in many cases, shutting our doors, still available very much through telephone and online, but not having our doors open to people, and that sends a certain message. So what we've been doing as a college to try to support people who've got ongoing healthcare needs, which of course don't go away during the COVID crisis, are a number of things. The first thing is we provided guidance for members about what they should be prioritising alongside COVID, which in many ways has had to be the principal priority. So we've been sending clear guidance about the importance of identifying conditions that look like COVID but aren't and are serious, things like meningitis or sepsis or whatever. Certainly looking after people who've got long-term conditions where those conditions are perhaps unstable or poorly controlled, focusing particularly on those. Certainly looking after people who might have signs or symptoms of serious illnesses like cancer, and finally providing preventative care for particularly, say, children for immunisation. So we've provided clear guidance for general practice about what they should be doing. And I think the vast majority of practices have done that. And we've also been working very closely as a college with NHS England and with the Department of Health and Social Care in order to reset hospital services as rapidly as possible, because we've been very aware from what patients have been telling us that they kind of need to get back. There's so long they can hold on to problems, but they need to get back into getting better access. I think that this work in general, just very quickly, Charlotte, just to finish, I think this work in general is a really important opportunity to reset the mindset that we've seen over the last 2 or 3 months, which I think actually, dare I say, rightly and necessarily, has been very focused on the system, the health service, and very focused on populations, and has almost completely ignored the personal patient view, the kind of interpersonal care, the relationship-based care, which particularly in general practice is so important. So we've kind of, in many ways, almost gone back to healthcare being something that's very transactional and very impersonal and not particularly patient-centred. And we need to really get out of that situation very quickly and get back to building on some of the amazing work that's been going on over recent years around patient-focused and patient-centred work. Charlotte, I hope that's helpful.
Thank you, really helpful. Loads of thoughts in my mind there, but before we kick off with that, and also thanks for all the comments that come through the chat. I'm going to ask a few of those questions in a minute, but I just thought I'll ask David first for his reaction, also maybe to what Martin has just said. Do we need to reset care now, go back to what we know works for individuals and carers and families, and kind of in a way downgrade our almost exclusive focus on not overwhelming the NHS? David, what's your take?
Thanks, Charlotte. Well, thank you for inviting me. And for those who don't know me, hello, my name's David McNally. I'm Head of Experience of Care with NHS England Improvement. Just apologies from Simon Enright. Simon would have liked to have been here, but as you probably guessed, there's an awful lot going on that he gets pulled into at very short notice, so he couldn't be with us. I was just thinking, as Martin was ending there, I could not agree more, really. But in a sense, we need to do both. We can't. We have to continue to meet the challenge that we've got. But I think the points that Martin's made are absolutely right. I mean, we really welcome this as a qualitative approach for looking at people's lived experience. I mean, as a patient experience team nationally, that's been central to the way we worked from day one. And I just think it's understanding people's experience, getting underneath the detail of that has to drive what we do and how we do it. So very much welcome that. It's interesting, I think, that a lot of the aspects of this are things that are very similar to the things that we've heard anyway, both in some of the national surveys and what we're hearing from heads of patient experience out in NHS provider organisations. So I think it reinforces a lot of that. I was very pleased. I mean, that really there's a really mixed message in there, isn't there? It's good to hear that people are still having some good experiences, even in the situation that we're in. So I was encouraged by that, but not surprised by some of the challenges that people were facing. And I suspect we'll probably come back to the question about open for business, but it seems to me that clearly is a big part of it. How do we actually get that messaging right? And there is a lot of work going on around that, which I can say a little bit about. I was very struck by the whole question about just the fundamental issues about how we communicate with people about appointments and preparation for different forms of consultation. It's a very simple thing that I think we can get right, and we need to make sure whatever the next period looks like, we need to embed that thinking into it. And then lastly, just come back to where Martin ended completely. We absolutely need to get back to person-centred care, get back to well, it's not getting back in some ways. I mean, you think about there's a key message in this about uncertainty, isn't there? And I think that we need to support patients in terms of that uncertainty, not just leave them to manage that on their own. And there was also a message about continuity of care. So making sure that people with long-term conditions are able to continue to have that fundamental relationship, which we know is at the heart of what makes for a good experience. So I'll leave it there for now. Charlotte.
Sorry, I think I was muted there. We could take this discussion into all sorts of directions, but to the people who are on the call, I thought it would be useful just to pick up the stuff that's come from the chat, really, to make it most useful to the people who make time this morning. There was a question about carers and whether National Voices is doing anything to understand their experiences. I'm going to talk in the next bit about what National Voices are doing to understand all sorts of experiences, but anecdotally, carers' experiences have washed up very strongly on our doorstep already. And we've heard of terrible examples of people just receiving a letter saying that their continuing health care has been discontinued and can they please rely on family carers. And, you know, all sorts of support is broken away with the closure of schools and, you know, if you have a child with special educational needs and all sorts. So my feeling is that the carers experience is a real break point where we need to really watch that the pressure doesn't get too big over the next few weeks and months, because that's what often stands between the patient and the crisis. So a real important question. A couple of questions, I think, from someone from BHF, Lynn and Rachel, our very own Rachel, about the need to really co-design now the way out of this and to arrive at new service models. So I don't know whether any of you have any thoughts on that. I'll hand that question to David in a second. And picking up a point from Neil Churchill here as well, about that the next few weeks and months are really crucial to make sure we keep what people are saying has worked and has opened up new ways of working, and we ditch the stuff or we complement the stuff that isn't working for everyone or for people with particular clusters of issues. David, have you got any thoughts on how we can make that happen, that patients and communities and the BCSE can help shape this discussion?
Well, I think that has to happen. I think that is the only way to do it, and I think that operates at every level. So I think nationally that's really important that we engage with the right stakeholders in doing that. So, I mean, you mentioned carers, Charlotte, and so we're working very closely with the Department of Health and Social Care, with Carers Trust and Carers UK on that agenda, and I think we need to do that across all of the work. There will be a lot of focus in terms of how we plan the next period in relation to each of the clinical areas, and I think it's really important nationally that that cancer and maternity and so on and so forth connect with the right stakeholder. They pick up, in a sense, the close working relationships that they had with that range of stakeholders in shaping that, and make sure that we've got people with lived experience informing that thinking, and it's also true at local level. So so the conversations that have been going on with a lot of our local systems have been with Health Watch. So I know a lot of Health Watch, and I know we've got some Health Watch colleagues. I'm glad to say on this call, and I've heard a lot of stories about Health Watches working with integrated care systems to hear voices locally and really feed that in. So I think we need to do it at all those levels, but I think it's critical that we don't run off nationally and do it without all of those voices. Otherwise, we won't have that experience in the middle of it, and we won't get it right. So no, it's really important.
Okay, loads of really interesting questions coming in. I'm going to hand one now to Martin, which comes from Tess Richards from the BMJ, about what experience data do we still need? Where do we need to go look for data now in order to make the right decisions? Have you got a view on what's the priority where we should kind of focus now in order to understand what's actually going on to make good decisions? If you could just do one bit of insight work, what question would you try to answer, Martin?
So I'm not sure whether Tess is referring to the right decisions about care now or the right decisions about how to redesign services in the future.
More the latter. I think it's more about future. Yeah.
Yeah. Okay. So I mean, my view is we need participatory research to bring together both researchers who are interested in service design and redesign and service users to help understand some of the key questions that we're addressing. And I've just put on chat the extent to which general practice has changed. We moved from around about 20% of practices providing triage at the front end of general practice to 100% in about 2.5 weeks in the middle of March. And we've moved from about 70% of consultations being face-to-face before the crisis to around about 15 or 20%, something like that now. So it's a dramatic change, and it seems to me that the public need to have the key say in whether those changes are right for them. To me, 100% triage, it can feel quite kind of mechanistic, a bit kind of production line like. Some people like triage because it's very efficient, but I'm not sure whether it's right. And certainly for me, as somebody who's absolutely passionately committed to interpersonal care and continuity of care, that's kind of the essence of general practice, where we add value. That's not to say that there aren't some transactional stuff in general practice, of course there is, but I think face-to-face appointments are a really important part of where general practice adds value. So to stick at the current 15 or 20% of face-to-face consultations, I think would be a disaster for everybody, including for the future of general practice. So without having a conversation with the public, with patients and with service users about what is the right kind of level, the right kind of style of consulting, then the risk is that we'll either stick where we are, which I think would be a mistake, or revert back to where we were pre-COVID, which I think would also be a mistake.
Yeah, very true. Really interesting question also here from Jacob from HealthWatch about HealthWatch England. 4.4 million people were on waiting lists as this all kicked off. So this is not just a primary care problem, clearly. I think a conservative estimate is that by now we've got about 6 million people on waiting lists. So that's, how do we restart that? How do we get practice going again for what we in this country deem non-urgent healthcare? And how do we have a conversation with people on those waiting lists and with the general public about what we can expect going forward, when large chunks of the health system will still be very occupied with the COVID response? I think I need to leave it there, unfortunately, with going through questions from the chat and very briefly introduce you to work we at National Voices are doing. And obviously you can still generate comments and feedback, and we will pick that up afterwards and also continue the conversation. But Laura, if you could just move on to a slide about our COVID voices, just to put that in front of the people on this call. So this is something we launched on Monday. We've been working on at somewhat breakneck speed for the last few weeks to try to capture some of the raw experience people have of what's going on for them right now. Everybody can contribute their experiences. We're trying to obviously weigh it more heavily towards people who've got ongoing health and care needs, because whilst I don't think ever have had as much health policy debate before in this country as we have now, so the whole news is obviously taken up with health policy, I think people with ongoing health and care needs, people who were patients and service users before all of this kicked off, are curiously absent from those discussions. So we want to hear from people particularly who have those needs, and also from people who look after them. So if you go on the website, we've only launched on Monday, we've got 10 people having contributed so far. And some stories there are carer stories, and they are very moving and sad indeed. We do this partly because we think it's a fantastic mechanism to collate a huge amount of insight, but we also do this clearly with an eye to influencing what's coming next. Whilst, as Martin has already said, some of the decisions that needed to be made very quickly and very harshly, and it wasn't always possible, clearly, to involve the people who are most affected. We think there's no excuse now coming out of the hyperacute phase of this crisis and whatever we want to call the next phase, because I don't think we can call it normal, not to engage with the people who will be most affected. So we, for example, think it's unconscionable to make decisions about extending shielding in perpetuity without hearing from people who are actually shielding. So Laura, if you go to the next slide, just to show people very briefly what this looks like. So we've worked with PPL and IUP and Social Spider on this. And on the landing page, there's a bit of an explanation as to what we're trying to do, and then you can already see some of the stories. And then if we go and actually look at one of the stories we've got coming up right now, and it is a story of someone experiencing service cancellations and service cuts, which, everything only ever really becomes tangible at human scale, I think. Really hits home how hard the landing has been for some people. So this family, recently bereaved, would have had 12 face-to-face appointments in a month normally to help everybody cope with what's going on, and that's all stopped. Injections in a car park, and then obviously the wider concerns that aren't just the clinical ones. Where's the food going to come from if you have to shield? All
So as Charlotte was saying, these quotes really bring home the challenges, a large breadth of challenges that people are experiencing. And seeing from the chat, there was a comment from one of you around the fact that it's not just about health, but it's about everything else that happens in people's lives. And the last quote really hammers home a point around mental health, and what people are experiencing will have an impact on their physical health, but also on their mental health. And this will take a long time to recover, and people will go through a range of phases during the lockdown and as we come out, and as things gradually return to whatever the new normal will be. But I think that one of the key things and key aims of this project really is around making sure that the new normal is a better normal. People have told us through the website about the hardship they are facing, but also the hope that they have, and that's the very motivation that brought them to share their experience, which is we can come out stronger from this. But that will work only if we do it together. Society can't move on only as a bit of it. Society has to move on together, and society is everyone. Is people with gardens and 2 bathrooms, it is people who are shielding, it is people with roommates and flatmates. Whatever policymakers and decision makers do, it has to take into account this whole society. So on this note, I would really like to open the floor up again, because we've had few more questions coming through the chat. So Sam and Rachel, can you please highlight some of the questions that we've not been able to address so far and direct them to one of our speakers? Sam and Rachel, you will need to unmute yourself to just ask one of these questions.
Hi, Laura. I'm just trying to get Charlotte back on the call. Rachel, could you inform everyone about the questions, please?
So I'm looking at some questions really around. I suppose to other members on the panel is the elements of co-design in this for me around how do we begin to design in some of the things we want to hang on to from the experience of COVID. Are the things that we're learning that we can take forward? So just a sense of that, and obviously there's been discussion around how we might collect more data, but what are the elements of how do we take that? You know, there's lots of data, but where might we go with that in terms of beginning to build new systems or new processes? Just that's sort of thoughts at the top of my head with that, really.
I wonder if just reflecting, if I could just reflecting on the research that we did, I think it's really important that we disentangle where we're talking about designing new systems or services and where we're talking about just improving the functioning of our existing services. Yes, there are ways that there are things that we can capture, and I know that we as a community, looking at the people on this call, a lot of the things that we're interested in are service design and co-production. Some of what we heard from the research is just tell people when you're going to call them and call them then. So I think it's helpful to disentangle. We don't need to run a co-production service design process to understand that you need to get that bit right. So I think there's something about how do we disentangle those things? How do we get the basics right so that people have the capacity to take part in those bigger, to engage with those bigger questions? And I think that's really difficult.
I suppose you're thinking about design both at a big level, but also, as you quite rightly, as you say, there is something about how do we almost design things in our everyday encounters rather than just ending up in them, but actually taking a moment to think before you make the phone call. What do we want to get from this together? So that might be something with you know, with service users as well, is having that opportunity to, what do we want to get from this together today? And as you quite rightly say, it doesn't necessarily need to be a huge big project. It could be something very small. So yeah, thanks for that. Any other comments around those sorts of features?
There are some questions that have come through on the chat that I've got here ready to put to the panel.
Thank you.
Okay, so we had one from Fitch on, it's interesting to hear that people are finding appointments are feeling less supportive and more transactional. And she asked, could this create a setback to efforts to integrate emotional and physical health in our services?
David, I mean, we have to make sure it doesn't, don't we? And I think, I mean, there is a wide recognition, isn't there, that there is a huge impact in terms of people's mental health around a lot of what people have gone through and will continue to go through. And so I think in some ways it's an opportunity to do the opposite, I think, in many respects. Because we know that people who found it particularly difficult need support that they may not have needed otherwise, and certainly part of the immediate thinking about what the services we need to switch back on and make much more available are around support for people who are struggling in that way. So I think there's an opportunity there which we need to grasp.
Okay, got another one through from Tessa just now. Possibly for you, Martin. Should the RCGP provide guidance to GPs on how to improve basic communication with patients during the next 3 months?
Yes, of course. I think that it's quite easy to slip into bad habits when you're in crisis mode, to perhaps be more directive, to be less patient focused. I think that is always going to be a risk. I think most GPs know that. I don't think the college needs to provide guidance for that. I think GPs will go back to consulting with patients in a way that's much more appropriate and much more patient-centred. I think a big issue actually is for younger doctors, and particularly for trainees at the moment, who have a very unusual experience of training at the moment. Sorry, there's a bit of background noise there. A very unusual experience of training at the moment, and a very atypical one. And I'm rather more worried about them having a significant part of their training in a unhelpful, slightly dysfunctional environment. And that's something that we really need to work on as a college.
Would anyone on the panel like to add to that, or are we okay to move on?
I think it's worth noting that this isn't just about primary care and general practice as well. Actually, I think in some ways general practice is, I'm going to generalise hugely here, general practice is where a lot of the innovation around person-centred care has happened. I think what's perhaps apparent from the work that we've done is that people are not, where people don't have that kind of base level of continuous contact with somebody like primary care or a midwife or a single point of care, then the other interactions become much more important. You know, the one time you have an MRI, generally that's very a rare occurrence, and the significance of it feels less, maybe it's sort of less personal than in this situation where that might be your only point of contact, or it might be a really, really kind of heightened situation. So I think there's something not just about general practice, but about how do we take, what are the situations in which we weren't getting person-centered care right before, and what are the barriers to those?
Yeah, thank you, Lucy. There's actually a very related question that came through from Lynn earlier in the chat, which was about asking whether the current virtual means of setting up appointments, like videos and apps, are they set up from the professional's point of view rather than the patient's? And how can we involve people more in how they're established and set up? Again, a general panel question, I think.
So, I mean, I think the answer to that very much has to be fundamentally we ask people that we ask them what works for them. and some of that will be testing things out, won't it? I mean, I think it's interesting in the chat earlier very much about some people's preference for using the telephone when they'd had the opportunity to use video. I think we need to give people that choice, and we need to make the options available to people. But I think it's about putting people in charge of their own care and keeping them in charge of their own care, isn't it? Fundamentally.
I agree with David there, Rachel. I think the onus is on general practice to provide a range of different modes of consultation. One of the reasons that we as a college have pushed back very hard on the Babylons of this world is they kind of segment, they take a group of patients out, generally those who have least need, and deliver a really good service for them, whereas they sought to be general practice that's providing a range of different ways into the service. I think that's really fundamentally important.
No, thank you both. We are very tight for time now, and there's actually loads of questions remaining unanswered, so we're going to save the chat and pass them on to the panel afterwards. So I'm just going to do one more kind of question looking at the future, which is from Deirdre, and it says, will the research in the long term look more fully at the social determinants of health which have been affected as a result of COVID-19? Because health starts at home, so how can we ensure that this is captured?
So yes, please, great question, really important. I think we talk a lot about social determinants of health. We talk a lot about health inequalities, and we do almost nothing about it, it seems to me. COVID has shone a light on inequalities and on the potential of providing social interventions for social causes of health, and we really need to seize that opportunity.
I'd say two things. So one is that we're very, very pleased that health inequalities is a very significant strand all the way through how we're planning the next phase, in a way that perhaps it hasn't been before, as Martin has alluded to there. So it will have a much higher profile in terms of every aspect of what we do from a national perspective over the coming months. But I've also been very encouraged by conversations with colleagues in local systems who are having those conversations locally and putting that at the centre of the way they're thinking about what they do. And I think if we're doing that locally and nationally, I think I'm very optimistic around that question. I think we're going to give it much more emphasis than we've done for a long time, which is absolutely what we need to do.
Thank you very much, all. So we have received a real stream and flow of comments and questions through the chat. So thank you very much for your insightful and active participation. We will capture those questions and come back to you on them. I just wanted to give the panel one last opportunity to really make a final comment, if you wish, in particular from Lucy, around what the next steps are for the research. What are you hoping to achieve through that? And equally, following that, maybe a last comment from Martin and David. Thank you.
Thanks, Laura. I think we set out through this research to do exactly what we've done today, which is to open up a conversation that's more focused on people's experiences and hear their voices. That's always what we're interested in. I think. Looking forward, the thing that is most interesting to me is where are decisions being made about how the health service adapts in the longer term, and how is the voice of not just the service user but the voice of the public and the citizens. What's the role in that? So that's the thing that I suppose I'm interested in, is how do we enable that in a way that doesn't exacerbate existing inequalities? Because coming out of lockdown, when and if that happens, many of the people who we need to hear from the most will have least capacity to engage.
Thank you.
Unless we do something about it.
Yeah, and that's exactly where National Voices, our COVID Voices project, comes in, to hopefully build that body of evidence and to provide people that opportunity so that hopefully we can give them a voice. Thank you. Martin and David, any final thoughts?
Yeah, so my kind of parting message would be a very simple one. The COVID pandemic has cast a very dark cloud over individuals and communities, over their health, and indeed over the whole of society. But there are silver linings to it. The opportunity that we have now to rethink what we do and how we do it, and in particular rethink the nature of the interaction between people who use services and professional providers is just massive. If we don't seize that opportunity, the default position will be to go back to where we were. And however radical the changes that we're seeing now are, that is the default position that will happen without an awful lot of effort on all our parts. But I'm optimistic that that will happen.
I completely agree with what Martin said. I think we people recognise that of necessity we've been for a short period in what we might characterise as more of a command and control kind of scenario, and there's an echo of that, I think, in the work when people were saying that they understood exactly what the situation that as it was and why things have necessarily had to, for a short period, be different. It is absolutely about us engaging with partners at every level and with people with lived experience. And there's a fundamental thing in that for me, which we don't always get right, and we need to get right now, which is that it's not for the NHS or local government or anybody else to decide how to engage with people. The way we engage with people with lived experience and with partners and communities is to ask them how they want to be engaged with. And I think that's what we need to do and thread that through everything that we do in the way that Lucy's just talked about as well.
Thank you very much. I just lastly want to thank our brilliant panel, our participants. I want to thank National Voices, Traverse, PPL for making this possible. Thank you all. I will play one more time the video, but if you didn't have a chance to see it at the beginning, so that this will remain switched on for another couple of minutes. But other than that, I wish you all a very lovely day and a very lovely bank holiday weekend. Take care, stay safe, and see you next time.
My name is Mohammed Khan. I've been suffering from prostate cancer for about 6 years, since 2014.
Good morning. Today is day 43 of my self-isolation.
I've had rheumatoid arthritis for about 5 years now. The medicines I take for my condition, which mean I'm able to walk and move around without being in constant pain, suppress my immune system. So if I was to catch the virus, my body would likely be unable to fight it, and I probably wouldn't be able to recover from it.
We used to take everything for granted. It's not the same. It's difficult. What can I say? Just carry on, really. Sometimes it's heartbreaking, but what do you do? We're all in the same boat.